Thank you so much, Dr. Ferris. I sincerely appreciate that. And thank you to everyone for joining us today. Let's begin. Today, we'll be discussing the heart of the matter, the gut microbiome's role in cardiometabolic health. We will go on a journey together today to understand the connection between the gut microbiome and cardiovascular disease. This will include the microbiome foundations, some information regarding cardiovascular disease that is still the global cause of death, the leading cause of death worldwide. So it's very important to link the foundational aspect of the microbiome with this significant leading cause of death. We'll discuss trimethylamine-N-oxide, that TMAO, that one of the links between red meat and heart disease. We will discuss the gut-heart axis. We know the microbiome does influence end organ status, and the heart is one of those organs. We'll discuss inflammatory dysbiosis, and this is a pattern that you will see in your patients quite often as inflammation and dysbiosis is rampant amongst especially individuals in North America, westernized societies. We will also discuss intestinal permeability. Intestinal permeability is a foundational component that does link the gut microbiome and cardiovascular disease. We will also discuss metabolic syndrome. Not only that, but metabolic associated steatic liver disease, which you are going to see in your patients. We will look at cardiometabolic markers and end with some cases and key takeaways that you can use in clinical practice today to help your patients. What is the gut microbiome? Well, the gut microbiome is not only the bacteria within the colon, it is the bacteria within the colon and their genes. Not only do the bacteria play a role, but they play a role as they interact with each other and as they excrete genes and end products such as short-chain fatty acids. The gut microbiome is a component of the gut-heart axis as well as the gut-brain axis that you may be familiar with. The microbiome is formed at birth. It is formed via the inoculation through the passage of the birth canal, or it is acquired via the hospital air in C-section individuals. So there is some studies out there showing that 80% of babies born via C-section tend to acquire the gut microbiome that is associated with the hospital air, so that their gut microbiome is dominated by bacteria such as Klebsiella and Enterococcus, and the healthy bacteria that you want to see, such as Bacteroides and Lactobacillus, are lower or even absent in the individuals born via C-section. Now, do not fret, because many of those differences were remediated by the age of 1. The gut microbiome is also greatly influenced by geography. So you have a unique gut microbiome that is similar to those individuals that are living in your home with you. You also have a microbiome that you share with your community or your country, and this does vary by geography. And of course, diet. Diet is a significant microbiome input, and this is a modifiable input that we can work with our patients to really understand how their diet influences their microbiome, and then how that goes on to influence systemic physiology. Often asked question is how short can dietary changes influence the microbiome? How long does it take for those to take effect? Well, diet can change the microbiome in as little as 24 hours. Those bacteria are very responsive and they have really small generational lives. So you can input a dietary input into the microbiome and make a significant change within the colon in a really relatively short amount of time. With regards to the gut microbiota, actually the first bacteria to colonize the infant colon is going to be Clostridia. Clostridia, unfortunately, gets a bad rap due to C. difficile, yet that is only one of over 300 different species of Clostridia. The majority of them are healthy, and we want to see them in abundance in the colon. Additional major phyla would be Bacteroides and Firmicutes, as well as the actinobacteria, the Verruca microbiota, Tourniquets, and the Proteobacteria. We will talk about those phyla today in relationship to some case studies. When we're talking about the bacteria, an important consideration is what's called bacterial abundance and diversity. Bacterial abundance essentially means how much bacteria is in the human colon. This makes a difference, but also systemic physiology influences not only the colon, but systemic physiology. Within the gut microbiota, there are over 10,000 microbial species, and the environment during the first 3 years of life really establishes your host symbiosis. This is not unlike the concept of childhood neurological development or immune system development. You're really thinking about that first 3 years of a life as a developmental stage that establishes a foundation for physiology for the rest of the lifetime, and the microbiome is intricately linked to that. So we see that by the ages of 2 to 5 years old, the microbiome begins to develop akin to the adult microbiome that would be for one's lifetime. Now, here we're taking a look at a diagram of the bacteria by phyla. We can see that a large amount of these bacteria are going to be Firmicutes, followed by Bacteroides, and then we see a smaller amount of Proteobacteria, Verruca microbiota, and the Actinobacteria. We can evaluate the gut microbiome by phyla. So this is the large family that they belong to. We could also look at bacteria by abundance and diversity. We can also look at specific key bacteria, such as Lactobacillus or Akkermansia muciniphila, because we know that these keystone bacteria significantly influence colonic health. And then we could also look at the bacteria regarding their metabolites, such as short-chain fatty acids. We will do that all today. Cardiovascular disease, I'm sure that many of you are very well versed in cardiovascular disease. This is a lifestyle disease that is largely preventable, yet it is still the leading cause of death worldwide. We know that early detection and reduction of risk factors is imperative. Microbial dysbiosis has been implicated in the pathogenesis of cardiovascular disease, including atherosclerosis, hypertension, and heart failure. So all of these considerations do have a gut microbiome role. And the gut microbiome, we should consider the gut microbiome like an endocrine organ because it does generate bioactive molecules that do alter physiology. So this is not an inert ecosystem. It is not simply about the defecation and elimination of excess nutrients. This is an endocrine organ that significantly influences physiology. We're not going to talk about this today, but when we're talking about cardiovascular disease, you do also want to consider exposure to lead. And unfortunately, we're learning more and more about microplastics, exposure to microplastics, and how those are now found in cardiovascular atherosclerotic plaques. Now, I'm sure we've all heard the advice to avoid red meat for heart health. Yet, did you know that that has an intricate link within the gut microbiome metabolism? The mechanism links there. The guidance to avoid red meat for heart health may be associated with the end product, TMAO. TMAO is derived from choline, phosphatidylcholine, and L-carnitine. These amino acids are largely derived from red meat, eggs, soy, beets, branched chain amino acids, dairy, and a new source of exposure would be those sports drinks, those power drinks, those caffeine drinks. They have a lot of carnitine in them, those drinks. So I would consider that as well. Another factor here is that vegetarians and vegans show a markedly reduced capacity to generate TMAO. We know that if you have a vegan and you give them a steak, you measure the TMAO in their blood, and it will be significantly less than an omnivore. The consideration here is that dietary carnitine is converted into gamma butyrobutane, which is then converted to trimethylamine, and that is then converted to trimethylamine-amine oxide. Now, the conversion's first step takes root in the microbiome as the bacteria convert dietary L-carnitine into gamma butyrobutane. The second step is going to be that some of these bacteria will then convert gamma-butyrobutane into TMA. And that's where we see that the vegans actually do not have that capacity. Therefore, they do not have the end product of TMAO. Let's take a greater look at this in detail. Again, the first step is dietary L-carnitine, largely derived from red meat. And the bacteria, their gene cluster converts that into gamma-butyrobutane. Once it is gamma-butyrobutane, then it needs to be converted into TMA. It is this microbial gene cluster that is absent in vegans or vegetarians. That is why you can give a vegan a steak and their TMAO production will be significantly less than the omnivore or the carnivore. So this shows us that there is a direct link between the gut microbiome and our diet and then TMAO. Additionally, we know from animal models that when animals do not have any gut bacteria in their colon, they do not create TMAO. What is TMAO? Well, TMAO, as we know, is a gut bacteria metabolite. Once it turns into the gut microbiome, and then we're talking about liver, and we're talking about the end product of TMAO and heart health. Our consideration here that we will discuss is metabolic dysfunction-associated steatotic liver disease. This used to be called non-alcoholic fatty liver disease, but we're learning now that metabolic-associated liver disease is actually a more appropriate name, as metabolic syndrome is rampant, and I'm sure you've seen this in your clinic. Additional considerations about the TMAO and cardiovascular consideration is that we know that fish consumption is associated with elevated plasma TMAO, but it's not associated with cardiovascular disease. Therefore, we know this is a complicated system. Additionally, higher TMAO is associated with advanced age, sedentary lifestyle, higher BMI, lower HDL, and individuals who are non-smokers. We're not going to advocate that individuals take up smoking, but we are going to understand this is a complex system. Furthermore, the gut-heart axis really does show that there's a connection between microbiome and cardiovascular disease, in addition to the TMAO consideration. Microbial dysbiosis has been implicated in the progression and pathogenesis of cardiovascular disease, including atherosclerosis, hypertension, and heart failure. One of the main factors is going to be alterations in microbiome abundance and diversity. When the gut microbiome veers from that eubiotic, that normal, healthy abundance and diversity, into a dysbiotic gut, that creates the associated metabolites that can contribute to cardiovascular disease and adverse health outcomes. Additional studies show us that in individuals with cardiovascular disease, there are a specific microbiome signature. These individuals have been noted to have decreased abundance of Bacteroides and Prevotella, an increase in Streptococcus and Escherichia. Escherichia species is more inflammatory and more associated with standard American diet. Additional considerations are higher Enterobacter, which I think with the Escherichia and the Klebsiella and the Enterococcus, we are thinking more inflammatory bacteria. And then lower in that very anti-inflammatory fecal bacterium Protenitzii, and that very healthy Ruminococcus navis, which is intricately associated with the mucosal barrier integrity and intestinal permeability. Now, there may be a consideration in that the gut microbiome associated with cardiovascular disease is also associated with the gut microbiome that's associated with liver cirrhosis. So again, we see a link here with hepatic function and health and cardiovascular disease and the gut microbiome. Additional considerations would be inflammatory bowel disease and myocardial infarction. So individuals that are diagnosed with IBD actually are predisposed to myocardial infarction risk, and that's going to be individuals that are relatively young, between the ages of 18 and 24. Now, the exact mechanism is not understood, but the hypothesis is that inflammations with IBD are dealing with chronic inflammation, individuals with IBD, and there's also a role for intestinal permeability. In those individuals, they have chronic intestinal permeability, which leads to decreased nutrient absorption. And so in these individuals, you want to monitor their risk factors with individuals that have been diagnosed with IBD, just to make sure that their cardiovascular markers are all within range because they are at high risk. Another consideration is fecal microbial transplants, as we know that these influence not only obesity, but blood pressure and clotting risk. Again, alterations in diversity and composition of the microbiome are associated with cardiovascular disease and metabolic health outcomes. The short-chain fatty acid acetate is a biomarker that may be associated when it's elevated, associated with a standard American diet. Inflammatory diet may be associated with cardiovascular disease. When we're talking about the gut microbiome, we're going to talk about inflammatory dysbiosis. Inflammatory dysbiosis is associated with the bacteria that have deviated from that normal healthy microbiome. This is also going to be associated with intestinal permeability, obesity, weight gain. We see this sometimes in individuals on ketogenic diet, high-fat diets, carnivore diets, the inflammatory microbiome, and individuals in the standard American diet. It's characterized by a high abundance of those pro-inflammatory bacteria and these LPS-rich bacteria, such as proteobacteria, enterobacter, Shigella, and Escherichia. These species have that end product LPS, which is inflammatory. And it's characterized by lower abundance of the healthy bacteria, such as Fecalbacterium proteinsiae, Akkermansia eosinophila, Eubacterium, Bifidobacterium, and Lactose brachiae. Healthy bacteria, and those bacteria tend to be too low. As a result, you end up with lower fecal butyrate production and end up with compromised mucosal barrier integrity function and metabolic disruption and maybe intestinal permeability as well. Here we have a diagram that sort of summarizes what we have been discussing. In the gut microbiome, if you have microbiome dysbiosis, you are going to end up with potentially lower short-chain fatty acids, which is going to inhibit gut barrier integrity. Another consideration is that very popular GLP-1 agonist medication that individuals are using now that is derived from the gut microbiome. So what we can see here is that the gut microbiome can influence these end product systems such as TMAO, which is associated with cardiovascular disease and stroke. Here we have additional information about the intestinal permeability and inflammation consideration. Gut microbiome intestinal permeability is associated with potentially cardiovascular disease in individuals diagnosed with IBD, but gut microbiome intestinal permeability is also associated with atherosclerosis and hypertension. And that's because when there's issues with that mucosal barrier, that tight junction becomes compromised, and then you have decreased nutrient absorption and vasodilation. So the intestinal permeability is associated with hypertension and atherosclerosis. Our next consideration is going to be metabolic syndrome. Metabolic syndrome is going to be individuals that have meet that criteria, and you see this quite often in your clinic. Approximately 25% of individuals at this point have all 4 of the criteria of abdominal obesity, dyslipidemia, hyperglycemia, and hypertension. In these individuals, we want to move beyond simply evaluating those traditional markers of cholesterol, LDL, and HDL. We really want to look at those specific markers of oxidized LDL, small dense LDL, non-HDL, apolipoprotein B, and you need to move beyond the Firmicutes bacteroides ratio just because studies are not consistent in that. We need to get individualized information about each patient. We need to look at the inflammatory microbiota profile, intestinal permeability, and again, test and address your individualized patient to see what's happening with their microbiome. We spoke briefly about the fact that TMA made in the gut-derived TMA then goes on to become TMAO in the liver, and that potentially in individuals with metabolic associated steatic liver disease, individuals with metabolic syndrome will potentially have metabolic associated steatic liver disease. The criteria for this is actually fairly straightforward. Your patient needs to have 1 out of the 5. So these criteria are linked to the metabolic syndrome criteria. This is a BMI criteria, a fasting serum glucose criteria, Hypertension or currently on a antihypertensive medication, elevated plasma triglycerides, or on a lipid lowering treatment. So if your patient's on a statin, they already have one of those. So you need simply one out of the 5 criteria. And then low plasma HDL. So this is something to be aware of in your patients and consider the metabolic function of their liver. The next step we will talk about is these specific biomarkers. We want to move beyond total cholesterol, triglycerides, and HDL to LDL ratio. So what will we look at? We are going to look at oxidized LDL, how much of the LDL is oxidized. We are going to look at that small, dense LDL, how much of the LDL is that tiny LDL that's able to participate greater in atherosclerosis and atherogenesis. We're going to look at the genetic lipoprotein A. We're going to look at the helpful apolipoprotein A1, and especially its relationship to the apolipoprotein B. We're going to look at GlycoMark. Postprandial hyperglycemia is very important in individuals. And we will look at the adipokines, leptin and adiponectin, as well as the markers of inflammation, plaque, homocysteine, and high sensitivity, CRP. So we're going to move beyond the traditional lipid panel to look at the real LDL culprits. These are not proportional to LDL-C. This is going to be oxidized LDL. That's how much of that LDL is oxidized. The oxidized LDL is the LDL that contributes to atherosclerosis. We'll look at that small, dense LDL and that genetic lipoprotein A. Oxidized LDL is very important because this is a strong independent risk factor for cardiovascular disease. Again, it is associated with the initiation and progression of atherogenesis. It is associated with myocardial infarction, angina, metabolic syndrome, and even hypothyroidism. You want to consider for these patients their lifestyle, such as trans fatty acid consumption, which is rampant, smoking, toxicant exposure, and oxidative stress, as well as insufficient antioxidants. We will talk about antioxidants today because antioxidants are healthy for the gut microbiome as well. The next factor is going to be small, dense LDL. Small, dense LDL, again, is a strong independent risk factor. This small, dense LDL is able to readily penetrate the endothelium because it is tiny and it is heavy. So it's easily taken up by the macrophages where it can contribute to atherosclerosis. This is associated with elevated triglycerides and low HDL. You don't want to look at these markers individually. You want to look at these markers together. A patient that has a small dense LDL, an elevated small dense LDL, a low HDL, and elevated triglycerides is a profile that's associated with cardiovascular disease. And there's a dietary component of that as well. So you can help your patient in that manner. For individuals with elevated small dense LDL, you would recommend exercise, weight reduction, niacin, EPA and DHA, as well as fibrates and statins. Statins have been shown to potentially increase the small dense LDL with normal triglyceride levels. The next component will be lipoprotein A. Lipoprotein A is the genetic factor here. So this is a genetic risk factor it's independent of the other markers. It is associated with premature heart disease, thrombosis, and stroke. Lipoprotein A impedes fibrinolytic activity. So your body is constantly creating fibrotic clots, and then it's breaking them down via fibrinolytic activity. Lipoprotein A essentially impedes that fibrinolytic activity, so therefore the clots cannot be broken down. So there is a greater number of clots in circulation, in systemic circulation. Therefore, you have increased risk of thrombosis and stroke. And this is a genetic factor. When you measure this marker, you won't really see it significantly change over individuals' lifetime. Statistically, there are no good interventions. It can be slightly decreased, and you'll really see that in patients where you have a high number of cholesterol, everything is very high, and then you bring it down. So you can see a compensatory decrease in lipoprotein A slightly. but technically there's no treatments for this. There may be some evidence for beneficial effects in individuals with fish oil or niacin. And next markers would be apolipoprotein A1 and cardiometabolic syndrome. Apolipoprotein A1 is very healthy. This ameliorates inflammation. It is increasing insulin dependent glucose disposal, insulin independent glucose disposal. So apolipoprotein A1, I think of that alongside HDL. You want a healthy amount of apolipoprotein A1. It is on the HDL species, so you want that apolipoprotein A1. It is anti-inflammatory. It is healthy. Apolipoprotein, conversely, is going to be an aspect of every non-HDL lipid particle in circulation. That's going to be the chylomicron remnants, the IDL, the intermediate, the LDL, the oxidized, the small dense LDL, and that genetic lipoprotein A. So it is the conglomeration of all of those lipid particles. That's why individuals are really looking at this this value, this biomarker right now, because they want to understand essentially how much do we have of all these non-HDL particles. So that's apolipoprotein B. Now, we'd be remiss to not discuss markers of inflammation, as we know that metabolic syndrome is increasing in the population. For the markers of inflammation that we have here today, we have plaque. Now, plaque is going to be an enzymatic marker associated with atherosclerosis. And then we have the marker of homocysteine. And we also have the marker of high sensitive CRP. So plaque is going to be associated with atherosclerosis, and it's a high risk of cardiovascular events, plaque instability, and coronary artery disease. Plaque is associated with macrophage-derived products. As mentioned previously, it interacts with LDL and oxidized LDL, and this is associated with endothelial inflammation. In individuals with elevated plaque, you want to consider, again, lifestyle strategies, and then you also want to consider their values of EPA and DHA, and check their HDL, and of course, lower all other cardiometabolic risk factors. Our next look at biomarkers will be the adipokines. We have leptin and adiponectin. Leptin is known as the satiety hormone. So this hormone signals the hypothalamus to suppress appetite and stimulate energy expenditure. What occurs in individuals is what's called leptin resistance. Here you have excess leptin because it's housed in the adipose tissue. When individuals have excess adiposity, that leptin is there, that adipokine is there, and it goes to the hypothalamus. And it actually is similar to insulin resistance in that once it floods the system, the hypothalamus then becomes resistant to that signal. What happens is the end product of that is individuals do not feel full after eating. So this is a vicious cycle because it's going to be your patients that are already struggling with weight and maybe metabolic syndrome, and they do not feel full after eating. So it's important to take a look at this value of leptin here. The thing to do when individuals have elevated leptin is really you need to remediate that visceral adiposity. But it is associated with atherogenesis and myocardial infarction and stroke. So we will take a look at that in some cases. Now, what about hyperglycemic excursions? We know that glucose control is very important for individuals, and we want to move beyond that fasting glucose, insulin, and hemoglobin A1C. Enter serum 1,5 anhydroglucotol, also known as GlycoMark. GlycoMark tells us about hyperglycemic episodes over the past 2 weeks. If your individual has an episode of postprandial hyperglycemia, then that GlycoMark will increase. Serum 1,5 anhydroglucotol will increase during that episode of postprandial hyperglycemia. Well, it takes 2 weeks to recover. So when we're looking at this in your individual sample, we can see what has occurred with regards to hyperglycemic episodes over the past 1 to 2 weeks. This is a good piece of information, because sometimes, as you know, your patient might eat healthy a day or two before coming into your clinic, in which that fasted serum glucose might not actually reflect their dietary patterns. So we have this marker here that shows about 1 to 2 weeks of hyperglycemic episodes and is highly correlated with cardiovascular disease and diabetic complications. Now, let's take a look at some cases. Our first case is a 44-year-old female. This individual is currently on a low FODMAP diet, and they suspect SIBO, so therefore utilizing that low FODMAP diet that's omitting the short-chain carbohydrates, fermentable oligosaccharides, disaccharides, monosaccharides, and polyols. Therefore, they're permitting themselves eggs, meats, cheese, almond milk, rice, quinoa, eggplants and potatoes, grapes and oranges, and omitting dairy, wheat, beans, and lentils, artichokes, onions, garlics, apples, and cherries. So those are important considerations. Beans, lentils, artichokes, onions, garlics, those are important. And this individual does note a family history of cardiovascular disease. Let's take a look. Now, remember at the beginning of this presentation, we talked about the phyla of the bacteria. Here we see the phyla represented as a web. Remember, the main phyla are listed here: Actinobacteria, Verruca microbiota, Tourniquetes, Proteobacteria, Firmicutes, and Bacteroides. These phyla are represented on the web there. A perfect result would be at that green hexagon shape. The patient's result is that white web superimposed on the hexagon. What we see for this individual is, instead of having that beautiful hexagon shape, we almost have a rectangle. That's showing us that there's an issue with diversity. Let's take a look at the next piece of information. We have the dysbiosis index and diversity score. For the dysbiosis index, we can see the score is 3. 3 is moderate, 1 and 2 are healthy, and then 4 and 5 are significant dysbiosis. For the diversity score, the inverse is true. You want a healthy, diverse microbiome. Remember, that means a variety of bacteria. For this individual, their diversity score is 2, so that's showing low diversity. We do know with low microbiome diversity, it is associated with some of the conditions that we've been discussing today. Now let's take a look further at the functional guilds of bacteria for this individual. The second piece of information we have here is talking about the specific bacterial guilds for this individual. We are looking at the bacteria that create butyrate, and we can see that those are outside the reference interval as indicated by the yellow toggle there. The gut barrier protective bacteria, those are within range at green, and the gut intestinal health bacteria outside the reference range. So the butyrate producing bacteria are too low for this individual, and that's going to potentially lead to lower butyrate and inflammation. And the gut intestinal health marker, that very healthy fecal bacterium proteinitsi, remember, we said it's lower in individuals that are associated with dysbiotic guts. Now, and that may be associated with obesity, diabetes. And for this gut health marker to be lower, that's potentially associated with unhealthy colon and potentially inflammation. The pro-inflammatory bacteria are within range, and the gut barrier protective versus opportunistic bacteria are within range. The next column there is independent of the first pieces of information. The first piece of information we discussed is about the patient's microbiome. The second column is going to be those metabolites. Remember at the beginning of this conversation, we said the bacteria and their metabolites influence systemic physiology. This patient has very low elastase, so there's digestive issues. Their butyrate is too low, potentially leading to altered inflammation in the colon and systemic physiology. So their butyrate is too low, and their total short-chain fatty acids are low. Remember, we saw that diagram showing us that short-chain fatty acids do influence cardiovascular outcomes. Now let's take a look at their cardiovascular risk profile. Their cholesterol is very high. We know this individual mentioned that they have a family risk for cholesterol. Their triglycerides look very healthy, So we're thinking that they actually do eat healthy. This potentially is a familial consideration if their diet is reasonable. Of course, they are omitting those FODMAPs, but some of the food, it doesn't look like they're eating a lot of processed food or excess carbohydrates, so their diet is reasonable. Their HDL looks excellent at 91. Now that LDL is certainly too high at 148. Additionally, we see, remember that non-HDL cholesterol, we talked about how important that is, and the oxidized and the small dense LDL. So those very important risk factors are too high for this individual. Going further down, we can see, thankfully, that the plaque is within range, the homocysteine is within range, and so is the high sensitive CRP. The next thing we can see is that the apolipoprotein A1 is actually higher. That makes sense because their HDL is higher, but that apolipoprotein serum B is a little bit higher as well because their LDLs are higher. All right. So what should we do for this individual? What we want to do is we want to start at the beginning. We want to support their digestion. Pancreatic enzymes will help support elastase in addition to eating hygiene. We talk so much about food hygiene and people know about food hygiene, but eating hygiene is equally important. That is having individuals sit down, smell their food, chew their food, eat in a relaxed state. That will help to support and facilitate the digestive function, such as secreting pancreatic elastase. For this individual's diet, we want to add soluble fiber. I know they're on the low FODMAP diet, but what happens is when you are avoiding those foods, you do end up starving the healthy bacteria, such as fecal bacterium praetonitzi, which we saw that was too low for this individual. When fecal bacterium praetonitzi is too low, what will happen is you will end up with lower fecal short-chain fatty acid butyrate production, and that's happening for this individual. So we want to remediate that low FODMAP diet. Consider reintroducing short-chain carbohydrates after 2 to 6 weeks. So we need to do some cycling here. Additional considerations would be polyphenols. And you may ask, should we use probiotics? You can certainly use probiotics, but those are temporary. I'd recommend using probiotics with foods to feed them, such as soluble fiber of 8 to 15 grams per day. That's going to be red kidney beans, lima beans, chickpeas, Jerusalem artichokes. Additional considerations would be fermented foods because fermented foods have the bacteria themselves. Regarding the individual's elevated cholesterol, we do want to consider reducing the consumption of saturated fat and increasing the consumption of omega-3 fatty acids. So there may be a little education about fat choices, avoiding margarine and choosing maybe butter or ghee, and then adding omega-3 fatty acids via fish oil or algae oil to the diet or supplementation. And then fiber is going to actually be addressing the cholesterol and the gut microbiome together. Regarding the elevated oxidized LDL, you want to consider polyphenols and antioxidants to address that. Polyphenols are also very nourishing to the gut microbiome. Regarding the small dense LDL, we're going to consider the lifestyle modifications, and we're also going to consider niacin. Niacin is the most effective FDA-approved means of raising HDL cholesterol, but also lowers LDL cholesterol. So lowering LDL cholesterol will in turn lower small dense LDL. And for the elevated non-HDL cholesterol, that is actually within range. There's nothing to do there. Now, our second case is a 58-year-old female on a ketogenic diet. This individual is consuming eggs, lamb burgers, and cream. Their BMI is within range. So let's take a look at the ketogenic diet here. We're going to start with the cardiometabolic profile for this individual. What we see right away is that cholesterol is elevated. Triglycerides look very healthy, but that makes sense because they're on the ketogenic diet. They're not eating carbohydrates. HDL is healthy as well, so that's great, but LDL is too high. Additionally, the markers of non-HDL, oxidized, and small dense LDL are very elevated. Moving further down, we can see that the ratios of LDL to HDL is outside the reference interval, as well as the apolipoprotein B to apolipoprotein 1. So that lets us know that there is going to be some lipid proteins that are able to contribute to atherosclerosis. And then when we take a look at the plaque marker here, we can see that there is an enzymatic marker that is associated with atherosclerosis and risk. So we know that potentially those oxidized LDL are contributing to atherosclerosis. And this HSCRP is too high for this patient. Definitely something to pay attention to, because usually when people are doing a ketogenic diet, they want to decrease their inflammation. So we know that we still need to work on that. For this individual, their apolipoprotein A1 is reasonable, which is great, but their apolipoprotein B is too high. The next piece of information we see is insulin is too low, and this is an artifact of ketogenic diet, as ketones will decrease insulin. Leptin is very low for this patient. It may be genetic, but it may be a factor of the ketogenic diet. You also see this in patients that have very low muscle mass. Okay. All right. So for this patient, what can we do? The cholesterol is elevated, but more importantly, the non-HDL cholesterol, oxidized LDL, small dense LDL, and plaque are all elevated. The non-HDL cholesterol is very suggestive of the chylomicron remnants that are atherogenic. And we know that we have that. In addition to that, we have the plaque formation, the HSCRP. So this is a very high significant risk. The oxidized LDL, the small dense LDL, and the very high apolipoprotein B are significant red flags. Now, the low creatinine may be consistent with the poor muscle mass. So you'll see this in patients that are on the GLP-1 agonists, but also patients that are adhering to a ketogenic diet, and their muscle turnover is too high at the moment. As we mentioned, low insulin is a factor of the presence of the ketones. So for this patient, we would like to retest this in 6 months after we've recommended remediation. Let's take a look at the microbiome. For this individual's microbiome, the first thing I note is that it's not making a hexagon again, and it's very pulled down to the bottom right corner. That bottom right corner is the proteobacteria. Those are families of many of the bacteria that we talked about at the beginning that are associated with cardiovascular disease. The proteobacteria are inflammatory. They tend to be, and they really like excess fats and excess protein. That makes sense for an individual on a ketogenic diet. The top left corner, actinobacteria, a clinical pearl, is they like vegetables. And the top right corner, Verruca microbiota, they like polyphenols. So an individual that is eschewing those produce and they're eating mostly meat, you can see that they have the elevated proteobacteria, this inflammatory dysbiosis. No surprise, dysbiosis index score is 5. This is a dysbiotic gut, and diversity score is 2. We have low diversity. Now, let's take a greater look at the key findings. No surprise here. For this individual, the butyrate-producing bacteria are outside the reference interval. The gut intestinal health markers are outside the reference interval, as are the inflammatory bacteria. And then that balance between the gut barrier protective versus the opportunistic bacteria is outside the reference interval as well. We do see for this patient muscle fibers and fat stain. That may be due to the ketogenic diet. And we see some short-chain fatty acid imbalances, such as propionate, and the butyrate is too low, just as we saw previously, potentially associated with inflammation. Klebsiella pneumoniae is cultured, and that is a simple dysbiotic bacteria that would be treated. So for the ketogenic diet, we do see that this is associated with dysbiosis. And exactly as we see here, it's characterized by elevated proteobacteria and Escherichiae and lower in those beneficial Clostridia and fecal bacterium praetonitzi, which leads to the low butyrate as we saw. This is largely due to a lack of soluble fiber. And in this individual, you may consider diet cycling. For this patient, we also know that there's elevated oxidized LDL. So for this patient, we want to increase the intake of low carbohydrate, vitamin C containing foods. These would be ketogenic approved. Bell peppers, broccoli, cauliflower, strawberries. Berries are usually tolerable on the ketogenic diet. And then we want to consider their fat consumption, moving away from olive, peanut, and avocado, and adding the avocado oils, and then decrease the sunflower, corn, soybean, and flaxseed oils. So we want to consume olive and avocado. I would not consume peanut, and then decrease the others. All right, our third case is going to be a 51-year-old male that is on the standard American diet and currently on Lipitor. this individual states that he does not have time for exercise. Let's take a look at this report. So for this individual, we can clearly see very low lipid values, and that makes sense because the patient is on that medication. That medication's working, so that information is there. The HDL is a little bit low, so we certainly want to increase that. But then going further down the profile, we still see that the HS, high sensitive CRP is there, and then the homocysteine is elevated. So these markers are too high. So that medication's working, but there is some inflammation. Furthermore, apolipoprotein A1 and HDL, that healthy lipid is too low. And then we see this individual does have that leptin resistance there. So that very high leptin marker. Taking a look at this individual's microbiome, we can see what's called that microbiome-induced standard American diet. Again, the web is pulled down towards that proteobacteria. We have the dysbiosis index score of 5 and the diversity score of 2. So low diversity, highly dysbiotic gut due to standard American diet. All of those key functional guilds of bacteria are outside the reference range. So the butyrate producers, the gut barrier, the intestinal health markers, and then that balance between the gut barrier and protective bacteria, that's going to potentially lead to mucosal barrier integrity issues and intestinal permeability. So what should we do for this individual? Well, for this individual, we certainly want to remediate that standard American diet. We want to add soluble fiber and polyphenols. We certainly want to address that low HDL. We're going to consider cod liver oil, niacin. We're going to address body fat and consider adding omega-3 fatty acids and consider discussing decreasing alcohol consumption. For the elevated CRP, the individual is already on statins, but we also need to consider decreasing the adiposity, potentially aspirin and low-dose methotrexate. For the low adiponectin, again, we need to look at lifestyle considerations and decrease that visceral adiposity, and same thing for the elevated leptin. So this is going to be a consideration of lifestyle and really working with this individual on that body consideration. So for individuals, when we're talking about the gut microbiome and we're talking about cardiovascular disease, we want to consider that they are intricately connected. And this quote from Hippocrates says, "Let food be thy medicine and medicine be thy food." The food that supports the gut microbiome and the food that supports the cardiovascular health are intricately related. And here's a summary of that information there. And you have this in your slides to look at later for notes. The food items that support gut microbiome and heart health are going to be fiber, polyphenols, oil, avoiding processed food, and specifically olive oil is very healthy. We talk a lot in our culture about meat consumption. We're very concerned with if individuals are eating vegan or carnivore, but that might be a secondary factor. We might want to consider these other factors first, such as how much fiber are we eating, our polyphenol consumption, our processed food consumption, and our consumption of olive oil. Oil consumption. Here's the cliff notes for soluble fiber. We did mention it's going to be 8 to 15 grams per day of soluble fiber. That's going to be a minimum of 30 grams of fiber per day. Standard American diet is really only giving 10 grams of total fiber per day, so it's woefully deficient. The fiber-rich sources would be red inulin, Jerusalem artichoke, garlic, onions, bananas. These will help to support the butyrate-producing bacteria that we saw in many of those cases were too low. And we also know that these bacteria are too low associated with cardiovascular disease, such as fecal bacterium proteinaceae. This also helps to support the immune processes and mucosal barrier integrity. Fiber itself has been associated with low blood pressure, lipid balance, and lowering total cholesterol. So we do see a connection there. Polyphenols are very important. As we mentioned, polyphenols will help with regards to supporting the very important lactobacillus, bifidobacterium, and Akkermansia muciniphila. Bifido and lacto have been associated with decreasing blood pressure, and Akkermansia eosinophila has been associated with managing cholesterol synthesis and insulin resistance. So you want that to be at appropriate levels in your metabolic syndrome patients. There's no recommended daily dose of polyphenols per day, but 1 to 2 grams per day has been known to be associated with a decreased risk of chronic disease. Olive oil is very important here. We want to pay attention to the fats. Not all fats are created equal. We know that olive oil is a mainstay of the Mediterranean diet. It supports the gut microbiome diversity, but it also supports blood lipids, hypertension, so it decreases that. It supports glucose and insulin sensitivity. So olive oil is healthy for the microbiome and the cardiovascular system. Final thoughts here. We want to consider food as medicine. We want to consider feeding that gut-heart axis. The key components will be olive oil, soluble fiber, and polyphenols. Consider the mechanism of action. We had some great information regarding TMAO. We want to test and address. Take each patient individually and take a look at their gut microbiome and those biomarkers, and take a look at their cardiometabolic health. And you could even consider testing for intestinal permeability, because we know that's related as well. And that would be done via zonulin family protein. Thank you so much. And now we'll have time for questions.